Good afternoon, everybody, and welcome. I'm Peter Hudson. I'm the Director of the Centre for Palliative Care. Thanks very much for coming along. It's great to see so much interest, although I'm not surprised given the topic of discussion this afternoon. I'd like to formally acknowledge the traditional owners of this land, the Wurundjeri Nation, and pay respect to their elders and families. I see a number of familiar faces in the audience, so it's welcome back and good to see you. But for those of you who've not come to a Centre for Palliative Care Hot Topic Forum before, if you could just raise your hand, please. Okay, terrific. Well, welcome. I hope you find it informative and I hope you come to another one in the future, but thanks for taking the time to be here. The focus, as you well know, this afternoon is on dementia and palliative care, and I was trying to think of something poignant to convey as a kind of appetiser for Deirdre's presentation, and I couldn't go past some of Karen Hitchcock's work. I don't know if any of you are familiar with it, but she wrote a terrific piece in the Quarterly Essay last year. I recommend it to you highly. So I thought I'd just give you a couple of brief vignettes from her article. The first is a quote from a geriatrician in Melbourne who said, "Our nurses are regularly yelled at by emergency department physicians when they send sick nursing home patients into hospital, people who can't be treated in the facility or who wish to attend hospital or have families who wish them to attend hospital. I wonder what they think a nursing home is and what a nursing home resident is. They yell, 'Why is this nursing home resident in my emergency department?' As though a nursing home resident is like a cockroach or a rat, completely unwanted and unwelcome, undeserving, and most surprisingly, not dead." Karen goes on to say, and this is in conclusion to one section of her article, and so this is a direct quote from Karen. She says, "Right now we need the resources to care better for the elderly in the institutions we have imperfectly built. We need adequate supports and deep social transformation so that many more people can live on in their communities and homes. We must remain aware of our ageism in every program and policy we implement. These changes are of pressing importance and they will ultimately benefit us all, even if, for now, we believe that we would rather be dead than demented, rather be dead than dependent, and rather be dead than grow old." Just before I introduce Deirdre, just a couple of things to make you aware of. We have allowed hopefully about 15 minutes at the end of Deirdre's presentation for questions and answers, and that's really important. So we do want to hear from you, any comments or insights. It's really valuable. However, we are filming this evening's presentation, so if you don't want to be on camera, if you just let one of our staff know if you have a question and don't want to be filmed, that would be appreciated. Also too, if you've got the time, we're going to meet for some drinks and some snacks afterwards in the room outside, so if you can stay on for some networking, that would be appreciated. A little bit about Deirdre. Deirdre Fetherstonhaugh is the Director of the Australian Centre for Evidence-Based Care at La Trobe University. Her research focuses on the translation and implementation of research evidence into practice. Deirdre and her colleagues also develop and provide education and training for the aged care sector. And Deirdre recently co-edited a book called Older People, Issues and Innovations in Care. Deirdre is a very good friend of the Centre for Palliative Care and completed a PhD with us, I think about 2005, was that? 2007. We're getting old, Deirdre, we're getting old. And recently worked on an important project looking at palliative care for people with advanced renal disease last year with the Centre for Palliative Care. And Deirdre's perfectly placed to talk tonight about dementia and palliative care, and I'm sure you'll find her presentation informative. Please make her feel welcome.
Thank you very much for that introduction, Peter. Yes, I'm not talking about kidneys today, I'm talking about dementia. But I'm also very proud to say that I'm also an honorary academic associate of the Centre for Palliative Care now as well. I just wanted to start, the Australian Centre for Evidence-Based Aged Care, it is really about the implementation of evidence-based practice, But I just thought I'd also let you know that we're the Victorian and Tasmanian Dementia Training Study Centre, and that URL there is actually a whole lot of modules online. There are 5 dementia training study centres currently in Australia. We're also a partner in the Dementia Collaborative Research Centre for Carers and Consumers at QUT. And on that website you'll find lots of resources, because there are 3 CRCs. One is around assessment, another one around treatment, and we're the carers and consumers. And as Peter said, we also develop and deliver lots of education programs for either nurses and PCAs in aged care. We have a SAMS agreement with the Department of Health here in Victoria, the aged care branch, so we do a lot of work with them. Specifically the sort of research we do, I'm not going to go into it, but I am actually going to talk a bit about clinical risk a bit later on. And more recently we have been doing some research around end-of-life care for people living in residential care. So why is dementia hot? Well, the number of people who have dementia, the likelihood of death, and I'm going to go through these, the presence of symptoms, the fact that there's lots of issues around communication and decision-making for people with dementia, the mega importance of advanced care planning or advanced care directives, and I'm actually going to talk a bit about reason about capacity and expectations of aged care versus capacity and expectations of palliative care services. And at the very end, I'll just touch on a bit of the recommendations from the recent Parliamentary inquiry, which could have, if they move with them, have some ramifications for residential care. Before I start, I just want to talk about the language of dementia and what we should not be talking about. And these are just some things. And I'm going to throw this thing a lot about medical staff who call, the dementia-specific cases. Rosalie would relate a lot to this. The sort of words that we use, given that the whole thing around dementia and personhood, if you start objectifying and talking about people as cases or wanderers or screamers, got a kangaroo loose in the back paddock, they're inmates of residential care, I don't think I'd like to be described as any of these things. And the Alzheimer's Australia actually have a whole thing on the language for people to use, that you don't talk about the demented. So I just sort of put this in a bit of a word cloud for you. So I apologise for people who know a lot about dementia, but I just wanted to sort of put it out there that it's not a single specific disease, that it's an umbrella term which describes a syndrome associated with more than 100 different diseases, but it is characterised obviously by the impairment of brain functions, including language, memory, perception, personality and cognitive skills. And the type and severity of symptoms and their pattern of development obviously varies according to the type of dementia. It's usually a gradual onset, progressive in nature, and it's irreversible. Now, the difference between someone with other advanced types of disease is that for people with dementia, it's characterised by advanced dementia is characterised by a prolonged trajectory of severe disability. And severe or late dementia is characterised by almost total dependence on others or the care and supervision of others. And the symptoms include very severe memory loss, limited language skills, an inability to make judgments or solve problems, not being able to recognise people, frequently incontinence, and requiring substantial assistance with personal care and increased behavioural difficulties. And I think if you look at the reasons why people with dementia are admitted to residential aged care, it would be mainly around behavioural issues and incontinence. They're the sort of 2 main reasons why somebody with dementia, who's living with dementia, would be admitted to a residential care facility. So if we look at the prevalence of dementia in Australia in 2011, there were 298,000 people with dementia. Now, the issue is that there are a lot of people that aren't actually diagnosed, that there are people who have a diagnosis of dementia, but there are a lot who probably have dementia that aren't diagnosed. And it's sort of foreseen that by 2020 we'll have 400,000 people, and this will increase to 900,000. Now, the statistics will say that 53% of people, permanent residents in aged care facilities, have a diagnosis of dementia in 2009 to 10. The Alzheimer's Association estimate this to be more around 70%. We do a lot of research in residential care, and the thing is that when we do it with people with dementia, we have to see that they've actually had a formal diagnosis of dementia. But there are lots of people that have got some degree of cognitive impairment and probably dementia that have not been diagnosed. Internationally, these figures just sort of blow you out of the water. That 2012, 35.6 million. And we're talking about mainly people that are diagnosed in developed countries, because we know that the mechanisms for diagnosis but as people are living longer in developing countries, the incidence. So by 2050, 115 million people with dementia. And there's also, stats talking about that someone's diagnosed every 4 seconds with dementia. I don't know whether this is a surprise to you, but to me it's a massive. I mean, people talk about the tsunami of dementia or the epidemic of dementia, but the other thing that I think is a lot of people aren't aware, that in 2013 dementia was the second leading cause of death in Australia following cardiovascular disease. That the estimated median survival, which obviously depends on when you're diagnosed as to how you sort of work the survival out, but obviously with Alzheimer's 7.1 years and vascular dementia. But it is difficult to estimate a prognosis, and if you look at this, we roll out this Lynn et al., these 3 trajectories. Karen and I rolled it out when we were looking at kidney disease as well, but we were looking at the middle one, not the bottom one. But if you can see, it's sort of a gradual demise towards the end. But obviously, some people with dementia may have other comorbid diseases which they may die from before the dementia. So Mitchell et al. Has done a whole lot of work following people with advanced dementia in residential aged care, and looking at the sorts of things that people die from, that people have a probability of having pneumonia of 41.1%, febrile episodes 52.8%, probability of eating problems. And this is, to me, is a frightening thing, that in the last 3 months, 40.7% underwent at least one burdensome intervention, whether that's talking about a visit to an emergency, hospitalisation. And if you look at this graph on the right here, the dark block is talking about the last 0 to 3 months of someone's life, the incidence of dyspnea, pain, pressure ulcers, aspiration and agitation. So, people know people with dementia don't have any symptoms. Yes, they do. In a longitudinal study that was undertaken in Holland by Hendricks et al. In 2015, or was reported in 2015, and followed a group of people as they were admitted into residential aged care, found that 47 to 68% of these people had pain on half-yearly annual assessments, that this was frequently persistent, and in the last week of life, 78% of those people had pain. And the same sort of look with agitation, except interestingly the agitation does seem to appease a bit towards the end of life. But the thing of note with this is that while they're common symptoms, the management of those symptoms is only often intensified at end of life, which sort of points to a lot of other things about what we should be doing better. The thing I was talking about, communication and decision-making at end of life, sometimes assessing symptom distress of someone with dementia can be quite difficult because of a loss of language skills. So you are actually reliant a lot on the observation of caregivers and professional staff. But it does show that there is such an important role in communicating with families and supporting them as proxy decision makers, and how important advanced care planning is. My centre, we're doing some research with, or some work with Respecting Patient Choices about doing advanced care planning with people with dementia. And I mean, the argument is that it should start as soon as the diagnosis is made, but often people don't want to hear about that when they're first given a diagnosis of dementia. But the reason being that the person with dementia can be quite actively involved in advanced care planning at that early stage, and eliciting their preferences and values and beliefs. And that it's not a one-off tick box, yes, we've done advanced care planning, that it should be revisited regularly. And in severe dementia, that the person's best interest may actually be served with a primary goal of maximisation of comfort. I just wanted to talk quickly about, we actually did a project which we finished last year looking at proxy decision-making for a person with dementia, because there's a huge emphasis on actually appointing someone as a medical power of attorney, but not actually how to support that person in making decisions on behalf of someone else. So we looked at people or talked to people who'd actually made decisions, and the decisions that were made, I mean, we didn't have driving in it at first, but that seemed to be the first decision that had to be made. But we looked at people who'd had to, mainly these were adult children, who'd had to make the decision about the move into residential aged care, medical treatments, transfer to hospital and end of life and palliation. And the findings sort of indicated that it was really important to know the person's wishes from the get-go, that consulting with others was very important, that even if someone was appointed as a medical power of attorney, that they could also still consult with others in the family or health professionals, but that there was a real business about striking a balance between respecting the known wishes, so the precedent autonomy of someone with dementia versus keeping them safe and looking at what their best interests. And I just think these were just some quotes that came from some of those participants, that how difficult this decision was to make about palliation or end of life. You know, it's like, I don't know, a continuum. Everything's smooth sailing and then something horrible, and then you sort of cope with that, and then something horrible. It's a journey. It's not like one thing happens and then you think, oh yes. And I mean, I've had cancer, I know. It's diagnosed. Yes, it's a shock. It's horrible. You deal with it. You either get better or you don't. But this is just keeps going, and it's a downward. You know, you have your plateaus, but then there's another hiccup. And that's that, and that's why it's so hard. So what about palliative care in dementia? Well, there was a white paper published in 2014, which was undertaken using Adelphi with a whole lot of palliative care experts. I don't know whether there was anyone from Australia on it. There was, I think so. And for you people who are experts in palliative care, none of this is new to you, but it's very interesting if you then look at aged care and see how much of this is actually happening in aged care. I think, you know, setting care goals, the whole thing about family care and involvement, and I'll go on a bit more about that, but prognostication, so I'm not going to. So Julian Hughes is a geriatrician and ethicist from the UK, does a lot of work actually with Alzheimer's associations around the world. I'm sure Rosalie's probably heard Julian speak it several times when he's come out here. But it's about encouraging people with dementia to live as well as they can, even the inevitable, by accepting the inevitability of death. And as all sorts of palliative care, that it should be all-encompassing, biological, psychological. Now, the Productivity Commission in 2011 stated that palliative care is core business for any aged care system. And I'd actually argue that aged care is palliative care. The problem is people always associate it with the absolute end of life, which I found when I was doing the work around supportive care and kidney disease, that we weren't even allowed to use the word palliative. We had to go to supportive just because the industry wasn't willing to accept it. But it's interesting if you look at palliative care reports that in 2010 to 11, Alzheimer's disease was only the primary diagnosis in 0.4 of separations from palliative care services. So it doesn't make up a very big percentage of the people that are referred to palliative care services. Palliative Care Victoria estimates that over 75% of palliative care recipients in Victoria are receiving treatment for cancer. And while I was working at the Centre for Palliative Care, I did ask a large community pal care service how many people they had referred to their service in the previous 3 years where the primary diagnosis was dementia, and there was only 42. So I'd actually like to do some research to see why are people referred to a specialist palliative care service from an aged care facility or even community with dementia, because it's interesting what sorts of reasons for why and what happens to them. But even though this only makes up a small proportion of what palliative care services work with, there's the ACFI, which is the Australian Aged Care Funding Instrument, which is how funding is done through aged care, indicates that by doing the assessments and the appraisals, that 1 in 18 of people living in residential aged care, they indicate a need for palliative care. And in the US, they're even estimating that 80% of people living in residential aged care would benefit from PAL care. And back to Julian Hughes, that would say that people with dementia are less likely to receive palliative medication and pain relief, they're less likely to have attention paid to their spiritual and religious needs, and they're far less likely, which is, I've just seen by showing you the statistics, less likely to be referred to palliative care specialists than people without dementia. So what about palliative care and aged care? Well, a lot of people would argue that it's suboptimal. And why is it suboptimal? Because of staff lack of awareness that it's appropriate, or find it difficult to actually apply this. But I've put through here a whole lot of major barriers. Now, I mean, I don't know whether you're aware, people who work in aged care would be fully aware about the inadequate skill mix in residential aged care. In Australia, 68% of the care provided, or the direct care staff, are actually PCAs and PCWs, and these people have done probably a TAFE certificate, which there is varying standards across Australia. And also with the fact that there are so many direct care staff, but the number of registered nurses working in residential aged care dropped 31% from 21.7% in 2003 to 14.7% in 2012. So it shows that, you know, you're not dealing with a staff member that are very qualified. This makes me nearly cry that we've been doing a project looking at, which I'll talk a bit later. We've had situations where the only person that can give the subcut morph is on call, and staff will put the staff members on call needs before the patient's needs. So they call that RN at midnight, and if they know that she's got to work again at 8, they won't call her overnight again to come in and administer the morphine. They'll wait. Another barrier which we've found in many of the projects we've done is about the lack of access and timely and appropriate medical management for dying residents. That there's, you know, often it's very difficult to get medication orders, especially analgesia for pain management and palliation at end of life. On a Saturday morning especially, you'll try your GP clinic first, but you'll always know that you've only got about a 30% chance of joy there. And quite often, like what happened last week, I had someone deteriorating quickly. Looked like they were moving to end-stage palliation. I rang the GP and he just couldn't make it. 2 booked up and he requested that we ring InReach. And I have a whole lot of quotes which I haven't got time to go into, but issues around people GPs not willing to write up and, you know, anticipatory prescribing for medication, analgesia, locums who don't know the person who won't order anything. And this has been a recurring theme through a lot of the work that we've done. And we found that quite a few residential care facilities will then start self-selecting their GPs, that they'll find some good ones that will do these things, and so they try and get them to take on more residents so that they can have these. So, yeah, I'm not going to say. There's also a mismatch between expectations of aged care and specialty palliative care, and I see that Jenny's in the audience because Jenny and Heather Lane did a project that looked at views of staff from residential aged care and community PAL care and found that managing expectations of all the people involved in the provision of care, that there was limited expectations of the level of care in residential aged care, and that there was a mismatch between the expectations of having a palliative care model and the role of this community PAL care in both residential aged care and the community care staff. And that there was tensions in addressing complex decision-making and satisfying organisational administrative expectations. I'm sorry, I just cut and pasted this, so it's not so easy for you to read. But, I mean, the palliative care staff thought it was core business, but it seemed that the people working in residential aged care weren't able to make the decisions about when it was time to have a sort of more palliative model of care, that the people in residential aged care weren't skilled at discussing goals of care, but then also from the other side, from the community PAL care, that they didn't really appreciate that the challenges that the people in residential aged care faced in undertaking goals of care discussions. So there seems to be a sort of a disconnect between the same, and I'm sure Jenny could give a lot more involved detail about this particular thing, but it just shows that there's different expectations between the services. There's actually another barrier is that there's a poor general understanding of dementia in the community and amongst many in the health profession. Andrew Robinson, who's the professor of the Wicking Centre down in Tasmania, they did a project that surveyed residential aged care staff and family members and found huge knowledge deficits, especially about the life-limiting nature of dementia and the onset of symptoms. So 50% of aged care staff who were surveyed and 60% of family carers did not know that dementia is a terminal illness. So if you don't know that, then you're not going to do much in the way of planning or so. And, you know, that there is a lot of lack of planning or communication about death between the person with dementia, their family members, health and care team. So there's also an issue around what consumers think versus what health professionals think. So Alzheimer's Australia did a survey on end-of-life care, and there were sharp differences in the perspectives between the care professionals and family carers. So, nearly 60% of family carers cited a lack of access to palliative care specialists or access to hospice care. They felt there was a lack of support. And I'm actually amazed that this is only 22% experienced difficulties ensuring the person they were caring for received adequate pain relief and around also curing. Whereas the opposite, that 75% of the care professionals thought that the people with dementia had access to palliative care services. So there's a bit of disconnect here between the responsibilities. But then again, 90% of care professionals indicated that they needed additional training on PAL care and dementia would be beneficial. I'm just going to talk now. We did a project for the Department of Health here with the aged care branch identifying areas of clinical risk in residential aged care a few years ago. And we identified 18 clinical risks, and if you can see the one, recognition of end of life, that was seen as a clinical risk because if you didn't recognise that someone was dying, then obviously they would have suboptimal care. So what happened with that was that then we developed up some evidence-based standardised care processes in these areas of clinical risk, and then we tried to implement them. And some of them we couldn't implement because of the lack of education and training of the staff in residential care. But the one around end-of-life care, which we completed in 2014, and Karen and Mark reviewed this, amongst some other people reviewed it for us. It's supposed to cover the whole care continuum. It gives you definitions of what we're talking about, and then they have things around assessment, intervention, evaluation, family involvement, and the resident or the person with, it's not necessarily just dementia, but if you're talking about that 70% of people in residential care have dementia. So we're doing a project currently at the moment around looking at capacity to implement this best practice end-of-life care, standardised care process. So how we're doing that is that we recruited 4 facilities and we're doing an audit against the standardised care process. So if this is best practice in end-of-life care, what is actually happening in this facility as far as its policies, its processes? Do they have an imprest? Do they use subcut infusions? All those sorts of things which are best practice. But we're also doing, looking at what knowledge is. So we developed up a knowledge questionnaire in reference to the standardised care process, so the sorts of things that people should know. We also used a pain tool, and we've also looked at how confident people are in being able to provide this or to have the skills in providing care to people that are dying. And then we've also done some focus groups and interviews with RAC staff. So I don't think these are very preliminary findings because we haven't finished doing the analysis, but we found that there is no formal processes for assessing family support and bereavement needs pre and post death, that they don't use validated screening tools like Peacock, which you use in palliative care, that any family meetings or if you're using, decision assist palliative care case conferences are ad hoc and they're generally conducted by the GP. That there's the workforce development is quite weak, that there's an expectation that just because you're a registered nurse that you'll be able to just do all the things that you need to do. And for unqualified staff, which is PCAs, that the training is actually on the job. So this person said, I think probably when I first started, so this is asking them how comfortable they feel about caring for people who are dying. It was a difficult thing. I found, a bit confronting at first, but no, not now. And how did you deal with it when you first started? Well, I think you just get thrown in the deep end and you've just got to sort of suck it up and just do it, Now, I was lucky when I was doing this work around the kidneys and I went to a communication skills training session. I don't think anybody in residential care gets any of that sort of support or education. The other thing is that there's a huge reliance, I don't know whether you know about residential in-reach services, that most of the big health services in Victoria run, they either call them residential in-reach or residential outreach, and their main brief is to prevent avoidable admissions to hospital. But they all seem to have sort of morphed individually, but the one thing is that the residential aged care is quite reliant on residential services, and that we've just finished doing an evaluation of residential inreach, and they actually do rely a lot on residential inreach to have conversations with people, to get pain analgesia written up, all sorts of things. This was something I came across in all the 4 facilities. People, this is care staff, not wanting people who didn't have a relative or someone to sit with them when they were dying, and felt very inadequate because they were unable to provide that sitting, sit down and be with someone who was dying. That they have timing issues with PAL care services, that we do have the local palliative care team as well, but we find most of the times it takes a lot of time for the referrals to go through, and then the processes to come, and by the time they come and review, the person might have already gone. So that's something I think PAL care services need to look at. And that they have a difficult time sometimes with families. So again, it's the communication, I think. Sometimes I find the families, sometimes grief is expressed as anger. So I've got families that are very combative with staff. I find that really, really difficult to deal with. So Mitchell, again, who I quoted before around looking at the symptoms of people with dementia, has looked at a lot of the research, and these sort of 4 things that she would see that needs to be improved with greater recognition of advanced dementia as a terminal illness. As I showed you, there's sort of a disconnect, people don't understand that. Better treatment of distressing symptoms. Well, I'd certainly first of all about recognising those symptoms, which I was also advocating for my people with kidney disease as well. Increase access to hospice and palliative care, as we saw not many people with dementia get referred to a specialist palliative care service and then the less use of costly and aggressive treatments. So what is being done? Well, I've been lucky enough to go to some sessions with palliative care consortiums, and I know that there is a big interface in some areas between aged care, and I think Renata will tell me, won't you, about issues of working across, palliative care consortiums working with aged care services. Decision assist, but interestingly in the work that we've been doing that I was just telling you about those 4 facilities, a lot of the people don't even know what decision assist is. So, and it used to have, I went to their 2-day workshop last year, but now I think it's all online and done by webinars. The Palliative Care Toolkit that was released, I think, in 2009, was it? No, I don't know. What date was it, Fiona? I don't remember. Anyway. And there's a bit of lack of knowledge about that, and that it's a rather cumbersome thing to use, and the onus is on a few people that have been taught how to use it. Link nurses, which I see have worked with some people, some aged care facilities have given, have these link nurses. Residential inreach services, and I forgot to write there PEPA. I was lucky enough to do a PEPA program when I was doing the renal work, and I think the idea of a reverse PEPA into aged care would be very helpful for palliative care staff to upskill people working in residential care. But these are a bit of my what else. Have a bit more specialist palliative care consultancy into aged care. It's not about accepting the patient and having to look, or resident and having to look after them forever, but actually providing some advice. I think it's really imperative around communication training, because people in aged care do not have specific communication training. From what I see of palliative care services and the use of volunteers and family support workers in palliative care services, which I don't think are utilised to anywhere near the degree in aged care services. Grief and bereavement resources and services, I think need. Now, just because the PECOG or the equivalent for aged care, I think would be a really good thing to do. I think PAL care training of palliative care people around, or staff around, behaviours in dementia, because I'm not sure that that's something that is covered very much in any palliative care specialist training. I've said the palliative care education and training of aged care staff, they're still putting their hand up for a lot more education. We actually have just finishing developing up a 10-hour, 8-module thing on recognising and reporting changes in residents' health for PCAs and PCWs. And one of the modules is on end of life, because if you're finding that 68% of the care is provided by direct care workers, they're the ones that go in and recognise the deterioration. And I'd also put it out there around the changing eligibility for palliative care services. Now, I don't know, correct me if I'm wrong, around prognosis of 6 months or less, but as we know, it's quite difficult sometimes to prognosticate for people with dementia. So whether that should be an exclusion or an inclusion criteria. So have we moved on at all? I mean, I found this, Ian Maddox in 1997 did the first national study concerning palliative care needs in RACs. And we're going back to the same thing. I mean, what he identified back in 1997, and I think they're the same things: a better assessment and treatment of pain and symptoms, advanced care planning, education, GPs, liaison. I feel like a broken record going over and over, and the liaison between RACs. So have we actually moved on? Now, I just wanted to finish with the recent parliamentary inquiry into end-of-life choices. Now, I'm not going to read these out, but there are several recommendations around residential aged care, so at least that's sort of being mooted. And so it's about an interdisciplinary approach, reduce inequities in the provision of palliative care. So there is recognition that palliative care services are not, or specialist palliative care into residential aged care. Recommendation 7, I think, is more around what the brief of residential in-reach processes or residential in-reach services. It's interesting here around the use of impressed storage of access to medications and quality care. So anyway, so there are, I mean, I don't know whether any of these recommendations will be operationalised and where they'll move to. So that's me, and I just really wanted to challenge you, and I just had to put a kidney in there just because I don't want you to forget that it's not just dementia, it's also people with end-stage organ disease of varying types. And yeah, I just sort of wanted to flag a lot of the issues, really. So, thank you.
Thanks very much, Deirdre. You covered a lot of material there in a short period of time, but very informative. As I said at the start, we really do value your insights and reflections and questions, so we have allocated plenty of time. So please, if you could let us know if you've got any comments. There is a roving mic. Mark.
Thank you, Deirdre. What I'm interested in at the Palliative Care Clinical Network, we're often talking about the interface of sort of the Commonwealth-run systems for residential aged care and the interface in Victoria. And commonly what comes up is the funding mechanism for extra funding in the palliative care arena. The terminology of palliative care is used for the last days of life and is often, if it's incorrectly imposed, the residential aged care have to repay the funding to the Commonwealth after that has occurred. So I'm just wondering, in your work, is that something that comes, and is there any moves afoot to try and change the ACFI?
I don't think there's any. No, I don't think that there's any immediate change around the ACFI. There's no. Not to my knowledge, I'm sorry, Mark, I don't think so.
It seems to be such a big barrier, but you don't hear a lot of momentum around discussion for it.
I know, and then
postpone applying it or applying for it.
I mean, they have 28 days to do the ACFI assessments to get the funding. I mean, it's awful. I mean, it's like, you know, we advocate that you should be doing comprehensive health assessment on older people as soon as they come in, and then the ACFI should fall out of it, rather than using the ACFI, the strict things of the ACFI, to fit people into pigs into round holes and so on. Yeah, but we don't actually do terribly much research around the funding sort of side of things. It's more around improving the care as it is given, provided.
And just stealing the microphone, my other question is around residential in-reach, so the geriatric services. You mentioned also that that's had an impact. What has that impact been? And you mentioned about that poverty of referral to specialist palliative care in the community, and I wonder what impact residential in-reach has taken on that palliative care mantle.
Well, it's an interesting thing, because the evaluation that we've done of residential in-reach is from the aged care in, because nobody would deny that residential in-reach is a fabulous service and it stops people from being, you know, transferred unnecessarily to hospital. But it's around what should be their remit. And it's interesting, if you look, some of them are staffed by, I know one service has a palliative care nurse practitioner who's part of the residential in-reach team. Some of them have aged care experts, some of them have emergency. So I think it often depends on what the area of specialty is of the people that are in the residential in-reach team. But I don't know whether you could find any statistics around what they refer. I mean, that one quote around ringing residential in-reach rather than the palliative care service, because it's much more prompt. Residential in-reach will happen today. It won't happen a few days down the track. So it is a bit about the responsiveness of the service. But some of the residential in-reach services provide an educative, they'll go out and run education as well as, but they are used sometimes for things that they shouldn't probably be used for. So, but I don't know what the impact has actually been on referral to. I mean, that's why I'd like to do some work with palliative care services to find out if people with dementia are being referred to their services, what is it for? Is it unrelieved pain? I don't know whether you know anything about, there's been these SBRTs, which are severe behavioural response teams that have been instigated in the last 6 months. Well, my understanding is that quite a lot of those referrals that are sort of behavioural referrals, but it's actually around pain. It's actually around unrecognised pain when they start delving into. So you would think that, yeah.
Rosalie Hudson. Thank you very much, Deirdre. As Peter said, an enormous amount of material you covered in a short time and so very comprehensive. Just a couple of questions. I'd be interested if you know of any research about the misdiagnosis of dementia. And I ask that question first before I emphasise some of the comments that you've already made. And that is to say that I would hope that as an outcome of this forum, that all of us here this afternoon will go away with a promise to ourselves and those that we work with, that whenever we come across a person with dementia, that we will ask a few questions. And the first is, who diagnosed it as dementia? And that relates to my question about misdiagnosis. Who diagnosed it and when? Because I've come across so many people who've said things like, oh, the doctor said Mum had a bit of old age forgetfulness, so we've put it down as dementia. So who has diagnosed it? How? And there are methods now, as compared with a couple of decades ago, when dementia in most instances can be diagnosed. And what type of dementia it is. You did mention that on one of your slides, but I think that's a valuable piece of information, particularly if palliative care services being brought in, because it does affect prognosis as to what kind of dementia it is, and quite often the residential aged care staff will not know because the person's diagnosis is just listed as dementia. For example, and I'm preaching to the converted here, but dementia with Lewy bodies has quite a different trajectory than Alzheimer's disease, for example. So the question about misdiagnosis, and the other question is about the comment that I hear frequently, particularly from aged care staff. We wanted to refer to palliative care, but we were told it's too early. So how often that crops up in your research? And can I have just one more? Can I make just one more comment about pain care? And that, I think, pain assessment is one of the most valuable services that palliative care experts can bring to the aged care environment, because, and this is no criticism of GPs who are, after all, generalists, they're not necessarily pain specialists, will often ask the question, are you in pain? Which is a wrong question for a person with dementia who can't understand the question. So the assessment is invaluable, and palliative care services to be brought in just to answer the question of proper response to pain, because we know from the research, and you would know from the research, that people with the same comorbidities but with dementia will have 50% less pain relief, just because they haven't been assessed properly. I hope you can unravel a couple of questions in there.
in response to your last one, I mean, I find that's why I also thought around that palliative care professionals need to learn about behaviours, because I mean, with the assessment of pain in people with dementia, looking at the behaviour is part of the assessment of pain. And I don't know, I mean, someone might correct me better, I don't know in specialist palliative care training whether that sort of thing is covered. Now, where do we go about the misdiagnosis? I would say that it's underdiagnosed anyway, and you're right that, I mean, we go through people's records in residential aged care and it just has dementia, which is not very helpful when, you know, you have to sort of have care plans and know the person and what to do and how to do it. The referral too early, I mean, that's why I flagged around, I mean, I don't see any reason why they can't be brought in, and if there's something that they can assist with, then discharge them from the palliative care, whatever it happens to be, would be my argument. Because it does seem that there is a difficulty in the time between the time of referral and then the time that, you know, and given that the uncertain prognosis and way of doing it. What was your other bit? That was pain.
Well, it was about a thorough assessment,
Yeah.
and actually looking at the comorbidities. That was, I mean, as I said, there's a lot of research to show that a person with 4 or 5 comorbidities, which is not unusual in residential aged care, but if you add dementia or include dementia, I mean, a person with end-stage osteoarthritis, for example, on PRN Panadol, I mean, this is the kind of assistance that palliative care experts can try and have a thorough assessment and make a good recommendation.
Well, I mean, as part of the ACFI, you have to use the PAS, which is a cognition screening tool, and the Cornell screening for depression, but I don't think that there's any other standard tools that are recommended necessarily to use. But I mean, I also find if you're going to use an assessment tool, you need to use the assessment tool, and then if you're going to have something, in fact, do something, then you've got to come back and evaluate whether it actually worked. Now, I mean, I find that often the pain assessment tool is off somewhere in some other place. They use the Abbey a lot, which is quite a useful, because it's a short tool, but I mean, you really need to go into a lot more depth. That's why I'm suggesting whether there is something like an assessment suite like you use in palliative care, the Peacock, which would be of some use. I mean, you know, we go into residential care facilities and they're all over the shop with what assessments they use. And also just ticking a box and saying, I've done the assessment. If you don't do anything with it, then it's pointless. So thanks, Rosalie.
Thank you, Deirdre. I'm her trainer, palliative registrar. How would you solve the issue of if a patient is lucky enough to have palliative care involved and have adequate analgesic prescribed, but there's not enough resources to administer the medicine?
Well, that's an ongoing discussion we need to have with the Commonwealth. I mean, I think it's recent that in New South Wales, for example, there isn't now a requirement that you have a registered nurse on the premises. So it's beyond me that one of the most vulnerable group of people, and we have the least skilled care work looking after them. You know, I mean, you can get in, you know, medication endorsed ENs and all sorts of things, but we really do need to look at the way we fund aged care and the expectation of the skills of people. I mean, I find it really interesting that someone can be in aged care and is looked after by a PCA and they get transferred to hospital and they go to intensive care or somewhere like that, and they've got all these people with huge qualifications looking after them. It's still the same person, whether they were in the aged care facility or whether they're in the intensive care. I mean, I know obviously they've got acutely ill or whatever else happens. But yeah, and I mean, the other thing is that aged care just gets such a negative rap from everyone, and we only ever look at the bad things that happen, where there is lots and lots of very excellent, good, fabulous things that happen in aged care as well. But I don't know how to solve it, but, you know, I mean, there's just recently been a parliamentary inquiry into the aged care workforce too. I mean, and I heard someone say, I think it was some people that were being made redundant from a car plant in South Australia, and they said, oh, there's lots of jobs in aged care. Well, I'm sorry, but the skills that you need to work in a motor, car plant are not the same as... And I mean, knowing how to communicate with people with dementia is, there's lots of work into that, but...
Hello, hi. I work in the geriatric evaluation management unit, just in St. Lee's here. I'm one of the physios there. And we have, obviously I work with patients pretty much every day who 90% of them probably have dementia or some form of. And interestingly, we have very dedicated carers who want to take these patients home and probably have a lack of understanding of how to manage the behaviours, which we even find challenging on the ward. Do you think these are the type of patients we should be referring to either inpatient palliative or community palliative to give education, guidance on behaviour management when it's appropriate to be contacting other services, that sort of thing?
I'm not sure, but correct me if I'm right, but whether or not the palliative care services are expert in the behaviours of dementia, I'm not pretty sure that they're not. So experts in symptom assessment and management and all the other things that palliative care does brilliantly, but I think that there is room to move as far as educating. Alzheimer's Australia try and do a pretty good job at trying to help and support carers, and there are other mechanisms. There's DBMAS, I don't know whether there's one.
Which is very good.
Yeah.
It's interesting because one of the biggest problems is behaviour management.
Yeah.
So, and I think that linking with that pain and all the symptoms with it, I think a lot of carers don't get that understanding at all, and don't. I think you try and teach a little bit where we are in the GEM unit, but I think then it just gets lost into the community, and then they don't access the right people sometimes. So, thank you.
I'll just get on board. Yeah. I work in a large hospital. I think you can extend the fact that people understand that dementia is a terminal illness to staff in larger hospitals as well, not just residential aged care. And I think that nursing education is really lacking in those sorts of areas as well, and in palliative care. They not receive an afternoon lecture in the whole 3 years on palliative care at the moment, or maybe a day. But really, probably that's a focus when you think of educating nurses now and having a large part of that, because our ageing population is just going to get bigger. It's going to be a bigger part of their job, and a lot of referrals come from these big medical wards or major hospitals. So nurses should be better educated. I think just general nurses on dementia and palliative care and aged care.
Oh, absolutely. And I find it interesting that in acute care we don't do any cognitive screening as a matter of course. If I turn back to my kidney favourites yet again, you're asking people to make decisions, decisions, but you don't even know whether they've got the capacity to do that. And the risk factors for kidney disease are the same as they are for dementia. So why aren't we doing any of this? Whereas in actual fact, there is quite a lot of, collection of data, I suppose, about people in aged care, but we don't. You and I know, working in a dialysis unit, we used to have people with, if they had a mental health issue, they'd often have a special sitting with them while they were on dialysis, but you wouldn't have the same for someone with dementia on dialysis. So, and yet, the same sort of issues. But yeah, I agree that there needs to be a lot more education. And everyone's very fearful of dementia. I don't know whether it is the most feared disease, probably cancer probably still is, because people worry about pain. But in actual fact, you're probably more likely to have your pain recognised and addressed if you've got cancer than if you've got dementia. And the other thing is that it's overt behaviours in dementia that get addressed, not those sort of, withdrawal, that sort of behaviours. People, if it's not worrying the staff or anyone else, then they don't take much notice of it.
There also seems to be a great reluctance for particularly analgesia to be there seems to be a great reluctance, particularly in nursing homes, for analgesia to be ordered because of a fear or a lack of knowledge, I think perhaps, just to think that somebody is going to be adversely affected by having opioids or whatever. And therefore, and also for it to be ordered as a PRN dose, or if not as a PRN, because very often it's not given as a PRN because of the lack of staff, as a regular secondary administration of a medication, so that at least the people get monitored on a regular basis. And we see that a lot in aged care facilities.
I totally agree.
Thanks, Deirdre. Jenny Phillip. I'm just struck by, and this is probably a poorly formulated comment, but I'm struck by the lack of knowledge and the lack of language that we have in medicine around talking about what dementia is and what people can expect, and the lack of knowledge that people have about it, and the sort of the constant barrage in the media of the tsunami of dementia, as you say, and how fearful we need to be of this, and what a ghastly thing it is, and how will we ever manage it? And I'm just wondering I guess I'm thinking, what role the media in all of this, in terms of having a much more mature, engaged conversation about what a dementia illness is, what the awful parts of it are, but also, what the, possibilities are for people with dementia and for families with dementia, because there are some possibilities, and people continue in their personhood and continue to have relationships and continue to have joy at times. And I guess I'm just thinking that perhaps the way that the media is conducting this conversation stops us from being able to engage in, educating patients and families and staff more fully.
I agree, and even the sort of thing you're talking about, fight dementia. I mean, it's the same language that has been used forever about cancer as well. But it should be about supporting people with dementia. And I mean, I've seen some absolutely fabulous things like bringing in mothers groups into residential aged care, and people that have been non-verbal for several years, and you bring some babies in and then all of a sudden it triggers a memory. People with early stage dementia going to creches and working one-on-one with little boys and girls that have got behaviour. There are some really positive things, but we don't hear those stories. And, this sort of stuff, it's always negative. But I mean, it's always negative about aged care. It's about the scabies outbreak or the gastro outbreak or someone dying, or it's never the positive things about residential aged care. And yeah, I don't know what the answer is and why we see that. Whereas, I don't know, the cancer stories aren't necessarily as negative as dementia. And it's interesting because at the moment the whole dementia research funding stuff around Australia is changing. I mean, we can't prevent it and we can't cure it, but we've got a whole lot of people here with dementia, so we need to be putting money into providing the best care for these people and supporting them with a disease that, yes, no one wants to have dementia, but yeah, sorry.
We do need to conclude, but if you could just join me in thanking Deirdre again for sharing her wisdom, and a small token of appreciation.